Welcome everybody to tonight's EndoANP webinar. We are joined by Dr. Guillermo Ruiz, who is going to talk to us about perspectives on iron storage and how it relates to endocrinology. So Dr. Ruiz graduated from SCNM in Arizona, which is where he currently practices. He practices at Integrative Health Clinic. He has really, while attending SCNM and while joining this clinic, he's really had an interest in the treatment of endocrine diseases, especially with a focus in thyroid health. And so working very closely with Dr. Alan Christensen, who many of you know, who's our current EndoANP president. He's really kind of expanded his knowledge and kind of dug deep into this area. And one of the cool things he does in his spare time is he hosts his own podcast called 30 for 30 Health, which you can see there on that front page, where he interviews a lot of influential kind of personalities in the health movement, and he really strives to advance naturopathic practices with an evidence-based medicine approach. So without further ado, I will actually pass the floor off to Dr. Ruiz, and he will take it from here.
Hello, everyone. I'm not sure you guys can see me. Can they see me now?
Yeah, we can still see you. So if you could stand for a little bit. Yep.
Yeah. So, this is a really cool subject. Not a lot of people think about iron disease or dyscrasias or, all these different things that can be investigated with a tiny little CBC and a couple of different very inexpensive lab tests. So this is a topic that is dear to me. If you guys have any questions during the presentation, if you can mark the slide, if you want me to go back to the slide, or if you just have a question, just let me know. I prefer to answer those at the end of the presentation, but if it's just burning you, go ahead and ask it. This topic is really cool. I've done a couple of presentations on this topic on different podcasts. I've never done an actual, full-blown presentation on the topic. So it was really cool to go back into what I've learned about iron disease, anemias, and just go back and re-educate myself and come up with new things and cool little facts that I can share with you guys. And then lastly, I hope you guys enjoy this. I hope this is as informative and helpful for your patients as it has been for me. We have done so many cool things within this topic at Integrative Health, and it has really changed people's lives. So without further ado, let's start our presentation. I don't know if you guys can see me or not, but I'm going to minimize this so I can continue with this. I guess I can turn off my camera at this point. Okay, so the overview of this is that I think that investigating these different types of anemias or iron storage diseases can be very helpful for everyone. We're going to go over signs and symptoms, how to identify this patient that might need a little bit of help with their CBC, the importance of having a good referral guide, in order to be sure to keep our patients safe. Remember, first do no harm. We're gonna talk about how to identify it, what type of labs we're using, what types of labs we're using for screening, and then I'm gonna give you guys optimal ranges, not just your reference ranges that that we know that sometimes can be pretty useless. I'm going to talk about how to supplement, and this is where we really shine in our profession, how to be efficient with our supplementation, with our diet choices, and ultimately even some IV treatments that you guys can use on your practice to help people with this type of presentation. And then we're going to finish off with iron overload, which is like the polar opposite. The iron is like a Goldilocks kind of thing, not too little, not too much. And then finally, so I'm gonna give Corey this PDF called the Ultimate Iron Guide. so this document that I prepared a couple of years ago for my patients, and it's just the easiest way for you guys to convey this information for your patients. Feel free to distribute it as much as you want. Take from it, add from it, comment on it, send me some feedback on it. But I think that this is way better than having the slides. One of my professors told me that trying to present on with someone else's slides or trying to understand someone else's slides is almost like brushing your teeth with someone else's toothbrush. So I think it's better, I put this together in my head and they make sense. And sometimes a lot of the information gets lost if you just have a set of slides. So I think this PDF is going to be a little bit better, and it expands on some of the things that I'm not going to be able to touch. Plus, it's fully referenced. So if you have any questions about any of the studies that I quote, you guys can go back and look at them and read them. They're fascinating. So why anemia? When Dr. Alan Christensen asked me, hey, would you like to do a presentation for EndoANP? I started thinking about, all the different topics and all of the endocrinology topics that we can cover. And I went back to the basics. Why anemia? If you look at those symptoms, if you look at the symptoms that you have right in front of your computer, less stamina, less energy, hair loss, foggy thinking, the foggy brain, dry skin, all of those symptoms could be caused by iron deficiency or different types of anemias, pain, joint pain, lack of elasticity in your skin. And I really appreciate that sometimes whenever we do something, we kind of like reinforce it through our practice. And I want you guys to take a step back and look at your patient and maybe have a different perspective, because I understand completely when you have a hammer, everything looks like a nail, and someone could be presenting with these symptoms, even hypothyroidism. And the way of treating them, the underlying cause could be some sort of anemia. So why not, have this different perspective and then try to expand our toolbox. So the importance of iron is, iron has so many different things that it touches. It aids in the thyroid hormone deiodination. It is involved in the secretion of ACTH. It's involved in respiration. It helps create ATP. We have a series of enzymes referred to as cytochrome P450. And this is a fancy way of referring to detoxification. But P450 uses heme, oxygen, and several other cofactors to transform toxicants coming from into the body. And we need it in order to transform chemicals coming in so that we can put them into our urine and feces. So iron not only is, it's this thing that your doctor told you, hey, you have anemia, here are some little tiny red pills, and then you go home and then you're constipated, for as long as you take them. Iron is key in so many things. It also helps in the immune regulation. It literally oxidizes pathogens. It uses the power of free radicals within iron to attack different pathogens and eliminating them. And this is one of the reasons we'll get to further down, that having excess iron can cause a lot of oxidative damage in your system. So as you can see, iron is involved in different pathways related to endocrinology, and in pathways that are lateral or to our focus, things like detoxification and fighting infections. So that's why I think it's very important to have good control of iron, and being able to educate our patients and being able to identify these things that could be so simple, so inexpensive, and have really, really cool outcomes for our patients. So let's start with anemia. What is anemia? There are so many different ways of defining it. I have this long, way of explaining it, but in essence, anemia is the inability for the body to transport oxygen to tissues. So you have your red blood cell, and your red blood cell is malformed. So, like for example, in the case of sickle cell anemia, where it's not very efficient at transporting oxygen to your cells, or it gets stuck in different arterioles or vessels, and now you have sickle cell anemia. If you are bleeding and now you have less red blood cells, you can't carry enough oxygen to tissues. Now you have anemia of blood loss. If you don't have well-formed red blood cells, and they either are too small to carry enough oxygen or too big and they can't get into the cell to deliver oxygen to the mitochondria, now you have macrocytic or microcytic anemia. So very easy way of understanding what anemia is. It's just the inability of your blood to carry oxygen. And as you can see, there's different ways that you can get anemia, and there's different ways to treating it. So, and this is very important because we usually associate anemias with women that have their cycle that's too heavy, and maybe they don't have enough iron because their menstruation is too heavy. Or now we need to identify and know that there are different ways that you can acquire anemias, and it's very important to identify them and treat them properly. So iron is the manifestation of anemia. You can have poor respiration, you can have symptoms of fatigue, fainting, you can have brain fog. Concurrent to anemia, you can have problems with digestion, you can have an overactive active spleen that is destroying red blood cells. So there's so many ways that anemia can present. One of the things that you probably learned in school is that this yellowing of the skin or skin bronzing, and this pruritus or the itchy skin, cirrhosis of the liver, all of these things can manifest as anemias. And so for this reason, anemia can be easily mistaken for an endocrinology problem. And that's why we need to have very good screening of all of our patients. We usually, for our new patients, we do specialize at our office in endocrinology, and we don't start with a complete iron panel. We usually have a CBC, your chemistries, and then we do a ferritin as a screening tool. And depending on those ferritin levels, that's when we decide if we want to do the TIBC, the serum iron, if we want to do the transferrin, just to make sure that we're not wasting any resources for our patients. So using our knowledge of functional medicine, we can prevent misdiagnosis. And I'm actually going to talk about some of the different ranges that we would be looking at for our patients. Okay, so let's say you have a patient and you suspect anemia, and you want to go and do the Cadillac of panels. Start with our very valued complete blood count. One of the most important, or one of the most important markers for me, is going to be the mean corpuscular volume. The mean corpuscular volume, it's basically the average size of all of your red blood cells. So in general, the more you become depleted in iron, the smaller your red blood cells become, and this marker will be lower with iron deficiency. So with the mean corpuscular volume, the way that I explained to my patient, you have a range of 80 to 100. If you are closer to the 80, your red blood cells are a little too small, and maybe they don't have enough capacity to carry oxygen to your mitochondria. If you're mean corpuscular volume is really high, closer to the 99s, and inching to the 100s, now your red blood cells are not dividing efficiently. So you have a big red blood cell that maybe doesn't have any of the substrates needed to create DNA, or they're just not dividing properly, and now they're way too big and they can't get into the into the um, into the cell and reach the mitochondria to help with respiration. Um, for the screening of our patients, I usually take a quick look at the ferritin levels and the mean corpuscular volume. Uh, Ferritin levels, if they are a little bit low, and if your mean corpuscular volume is inching outside of the 90s, that's when I start my ears perk up, and that's when I start to think about iron deficiency anemia. I'm going to repeat this a couple of times during this presentation, but very, very, very important that if after you take action and you achieve optimal CBC levels, if after a couple of months or maybe a couple of weeks that patient shows up at your practice and their ferritin is bottomed out again, and that CBC is starting to look a little bit outside of the optimal ranges, we cannot exclude an ulcer or cancer or something more serious. So it's very important that if you have a patient that has been coming to you for a while, and they have unresolved anemias, that we do a thorough referral to a hematologist or a gastroenterologist, to make sure that we're not missing a bleed somewhere that could have really bad repercussions in the future. Okay, so let's start with macrocytic anemia. Macro being big, cytic means cell. It's huge cells that are not dividing properly. This is the most common thing that we see, the most common type of anemia that I see in our practice. And it's characterized by having, high MCV, sometimes, 93s, 94, up to 103. That's when, even the reference ranges are saying, hey, you have your red blood cells are too big. Very easy to treat. We see a lot of success treating macrocytic anemias with supplementation and maybe a little bit of digestive support. Within the macrocytic anemias, we have two different types of anemias. We have the megaloblastic anemia and the pernicious anemia. The megaloblastic is a type of macrocytic. Pernicious is a form of megaloblastic anemia. I know it kind of gets confusing there. Pernicious anemia usually occurs due to low levels of B12. This is a important one, because if a patient is coming to see a naturopath, usually they're either taking a B12 supplement or they are taking a multivitamin with good levels of B12. So sometimes other things can be the culprit of having these big red blood cells. The reason this big red blood cells happen is because B12, folate, zinc, and then things like phosphatidylcholine, phosphatidylserine, all these things create the red blood cells. And if we are low on them, then we don't have the resources to create new red blood cells. So, so an easy thing to do would be to just give, some B12 lozenges and, and hoping for the best. But really well documented that a more complete approach can be more healing, or can become more efficacious faster than just going one by one. One one of these different supplements until for the next. Other common nutrients that are important for iron metabolism are vitamin A. It helps iron metabolism two ways. First, it enhances iron absorption, and then second, it helps get iron out of storage so it can be used. So there are several situations where the conversion of beta carotene to vitamin A is hindered. So if you're relying on fruits and vegetables for your vitamin A, you may come up short. So that's why it's very important to use vitamin A and not beta carotene. The second nutrient would be copper. Copper is essential and does a lot of the same things that vitamin A does. It helps you absorb the iron. It helps move it out of storage. It also plays a role in the synthesis of heme. Best way to get enough copper is to ensure you have a variety in your diet. So, your nuts, seeds, legumes, dark chocolate, shellfish, organ meats, liver tops the chart, with 100% of your daily needs with 3 ounces of liver per day. And the signs of symptoms of copper are not that obvious. So laboratory testing has to be you have to be very careful with the testing. We like to test RBC, and then if you are giving zinc, zinc and copper compete with each other, so it's a good idea to have a copper supplement. We learned in school that that we can use food to reverse anemia, and unfortunately in practice, I really haven't been very, very successful with just food. So a little bit of supplementation usually helps better. So diet related, taking PPIs, lowering the pH of the stomach can affect iron absorption. Eating good proteins like taurine is very important for our iron absorption. Correcting digestion, using some high quality digestive enzymes. Sometimes our food choices don't agree with our needs, and in the case of, for example, vegan diets, you might be more prone to need supplementation. But just being aware is just the most important thing. I'm gonna say something about methylcobalamin. Methylcobalamin can be excitatory on people that have MTHFR mutations. Very rare, but usually it's very easy to get methylcobalamin. If your patient has problems with it, you can use adenosylcobalamin or hydroxycobalamin, and that doesn't have the methyl group, which could affect some people with MTHFR hypersensitivities. Folate, not folic acid. If you guys are familiar with Ben Lynch, make sure you guys use folate and not folic acid. Phosphatidylcholine is an interesting one. It's a phospholipid, and the degradation of the phospholipid bilayer in the red blood cell kind of signals when the red blood cell is going to die. So if you have low levels of phosphatidylcholine, you're not going to be making the most efficient or the most beautiful red blood cells. Those red blood cells are going to be a little bit more fragile than if you have good levels of phosphatidylcholine. Phosphatidylcholine has been very helpful with some of my patients that have, that we've tried a bunch of different supplements, and then what they needed was phosphatidylcholine, and that fixed that, that macrocytic or megaloblastic anemia. Another thing that within the macrocytic anemia that I want to touch on was that heavy metals can cause problems with red blood cell formation. I have a patient who had suffered from porphyria for many years, and it had gone to many different places, and they weren't able to figure out why she was not making these beautiful red blood cells. She had, poor conversion of red blood cells, and constant fatigue, a lot of mental fog. And we decided to run some a toxic panel, and she had huge levels of lead. She grew up in India and had been eating off of clay pots for most of her childhood. We chelated her, and this is about 2 years ago. And to this day, her porphyria has not returned. Now, what are the chances of being able to do that? I don't know. Maybe this is one patient in a million, but we helped her tremendously just by doing our naturopathic modalities. So you can see this rubric right here. It allows you to differentiate to see if you have a problem with nutrition, a problem of absorption, or if it's an inherited problem being caused by faulty blueprints. So once again, if you've tried all of this, especially specifically if you have a patient that got better, that their symptoms were better, their lab work got better, and then 2 months after that they come back and they're like, hey, I'm starting to feel like I used to feel. Make sure you refer. Make sure you refer. A choice is yours. If you have a good referral to a hematologist, that would be a good place to start. Or and chances are, if with that presentation, that hematologist will refer to a gastroenterologist for an endoscopy and colonoscopy. Let's keep our patients safe, because you can always do an iron infusion. You can do mega doses of B12 and correct those levels for a little while, and then again, you have not fixed the underlying cause of the problem. So how do we treat iron deficiency anemia? Again, iron-containing foods. That would be the most important, with an emphasis on proteins like animal proteins, because iron in animal proteins is tied to heme. And on the left side, you can see that the absorption of iron in iron that is attached to a heme protein is a one-step process. It goes through the heme transporter. But in non-heme iron, okay, you have to actually convert that, lose an electron from +3 to +2, and then it can go in, and then you can go ahead and absorb it. So it is just so much easier for your blood iron levels to go up if you are eating animal products. Liver capsules, I have not had a lot of experience or success with just using liver capsules to take someone that is anemic and getting them into a good place. But I have had some success with people maintaining their iron levels with liver capsules. And liver capsules are a little bit better than your iron supplements, because I see it more like a food source. You have your vitamin A there, you have some copper, you have a little bit of magnesium, you have your heme iron. So that whole synergistic, encapsulation is going to be a little bit better for someone that refuses to eat organ meat. I'm pretty sure you guys have heard about blackstrap molasses. Never had any success with blackstrap molasses. It's high in the glycemic index. It's non-heme iron. Might taste pretty good and might be easy for patients to comply if you tell them to eat some blackstrap molasses. But I haven't seen really good results with that. Okay, so in terms of efficacy, okay, there are different types of iron, and different types of iron work different. Okay, the most effective form that has the least amount of side effects is going to be ferrous bisglycinate, commonly known, it is marketed as ferrochel. Again, have not had a lot of good, I haven't had any good results with trying to bring someone that was iron deficient anemic to normal levels just by supplementation of ferrochel or this ferrous bisglycinate. You have to do pretty high doses, and you have to always include some vitamin C in order to enhance its absorption. And even then, it is very difficult to get those iron levels up. Ferrous oxide is horrible. Ferrous sulfate, causes a lot of side effects. And then I'm going to talk about another problem with iron coming up in supplementation. Okay, so populations with iron deficiency fall into two categories. You can have a chronic issue that disturbs absorption or some cause of blood loss, and the second category is iron deficiency. Okay, if you have the chronic condition, important to work with a doctor that knows how to find the reason why you are deficient. A lot of folks fall into the second category, and as a result of the dietary patterns. So restricting foods, like you have a lot of people trying, intermittent fasting, or reducing the protein intake, or doing all of these different things that
Oh, Dr. Ruiz, it seems like we lost your audio. Can the audience hear me in the chat box? We are still on.
Okay, cool. Thank you.
Yep,
Okay.
yep, I can see you. Okay, yep.
Okay. Excellent. Where was I? Okay, so I was saying, as a side note, I don't understand how I have patients walking into my office with a ferritin of 7, with a ferritin of 8, that have not been assessed for iron problems. It baffles me. I don't understand it, but that's a homer. That's a home run. If you can get one of those patients, if you can get him, to your IV suite, and get him, an infusion, those are the patients that are going to be like the best responders. But then you still have the homework of figuring out why they are iron deficient, and that's where we shine, because it could be that they have PCOS, that they've had huge, horrible, painful menstruation, heavy bleeding, and it's never been corrected. It could be that maybe they have a chronic infection, maybe their digestion is poor, and now we're getting to the underlying cause, and we are helping people. I know in school they scared the living crap out of me about iron infusions, and it is true. Iron infusions can be scary. iron dextran, you know, a reaction 1 in 3 out of 100. So I really don't like the dextran form of iron. In our practice, we use iron sucrate. It's less incidence of reactions. I've done probably hundreds of infusions, and I've not had one. I'm gonna knock on wood. And very safe, very easy. It's especially with all this FDA problems that we're facing, where they're making it harder and harder and harder for us to create to administer iron IVs in general. This only takes 250 cc's of saline or 5% dextrose and 5 cc's of iron dextran that comes in a single-use vial. So you basically just use 5 cc's into 250. That's one ingredient into one bag. So there's no problems with formulations. And but we do have to be very careful because infusing a bunch of iron can cause increased oxidation. We need to make sure that if this patient is toxic, that their detox pathways are functioning, because once that iron starts working, everything starts working. Your detox pathways, your infection fighting abilities. So you can have a bunch of different ways that your patient can feel pretty crappy if you're not careful with your iron infusions. Now, one of my favorite topics, because it just highlights how elegant and amazing our bodies are, is anemia of chronic disease. And I'm gonna give you a little bit of a story. Okay, there was a time where some missionaries went from the United States, went to Africa to a place that was stricken by malaria, and you know, they wanted to do some good, and you know, these are pretty malnourished kids, and they started testing, you know, different things, and they started testing their iron levels, because those little tiny red pills that make you constipated are, you know, pretty inexpensive. And they checked, you know, this kid's levels, and they gave him a little bit of iron, and then they started having fulminant infections of malaria. And the kids, you know, some of them died. That the WHO now mandates that if you are going to supplement iron in a place that is inflicted with malaria, you gotta have a damn good anti-malarial protocol established. Why is that? Well, this is anemia of chronic disease. Anemia of chronic disease is this phenomena where your body hides iron from itself. Why? It does it because iron is so important. It is just so important that different organisms have different places in their body, or in their DNA, where they use iron in order to grow, or to duplicate, or to regenerate. So without iron, this organism cannot replicate. So our body is so smart; it hides the iron and the spread of the infection. And so you're going to feel a little bit crappy. You're going to feel fatigued. Your ability of taking oxygen to your tissues is going to be compromised. But that's you know, it's going to be compromised at you know, but you're not going to have that fulminant infection. It also happens with cancer. So that's two places where we have to be very careful with with the way that we supplement the iron, or who we are supplementing with iron. This is a very cool little graph right here where you can where it shows you um, the difference between anemia of chronic disease and iron deficiency anemia. And the biggest thing that you guys gotta, look for is a person with low iron and high ferritin. If you have a person with low iron and high ferritin, think infection. So you could think about, a intestinal infection. You could think about, a systemic infection. You could think of even, or you can think about cancer. Again, cancer needs iron in order, all the cells in the body need iron to replicate. And if you're hiding the iron, that's going to slow down the growth of the cancer or the growth of that infection. This is a fascinating discussion. It probably deserves its own seminar. But in short, some people, have reservations about iron repletion when chronic infections are present, and that's for good reason. There are studies showing iron repletion can worsen infection outcomes. Even the Cleveland Clinic acknowledges this as well, and that's why the type of iron you use is very important. Okay, so there's the bisglycinate form of iron has been shown to be less prone to have this problem with the infections. This is almost like a philosophical question, because if you have a patient with anemia of chronic disease that that they could benefit, because their iron is low, should you give them an iron infusion, or should you treat the infection? I have been pretty that if I have someone with an anemia of chronic disease that we found the infection, with a confirmed infection through a CSA times 3, or through good a Genix panel, or anything like that. If we have a confirmed infection, and I start treating the infection, that iron level goes up, on its own. With iron deficiency anemia, that's where the philosophical question comes into play. If I give that patient an iron IV, they have low iron and they have low ferritin, will that infection just go wild? I feel pretty safe that as long as that patient is being treated by that for that underlying infection, I've not had any bad outcomes. I'm not knocking wood once again. But yeah, I've been pretty successful with treating both at the same time. Just make sure we find that infection, and if you're unable to find that infection, referral could be granted, especially if you have a patient that could be having some digestive cancer or colorectal cancer. And then now we have, let's flip it. Let's flip it and let's talk about the opposite. Let's talk about iron overload. This is such a cool little paper. They had 18 patients with overt diabetes, and their ferritin levels were, through the roof. And they used this drug called deferoxamine, which is a iron chelating agent. Okay, and this chelating agent that is very specific for iron. The iron dropped, and all of their symptoms of diabetes went away without changing diet, without changing anything. The idea is that diabetes is an oxidative disease. You have so much energy, you have so much sugar, and that sugar is going into the mitochondria, and that sugar is going into the Krebs cycle. And Krebs cycle is like pumping out ATP like crazy, creating a lot of reactive oxygen species that is very, very oxidative. And so your body says, okay, no more insulin. to decrease the influx of oxidation. And they've proven this. They've taken cells and they ozonate those cells, and those cells, without any extra sugar or glucose, those cells become insulin resistant. So it makes a lot of sense to me that if you have a lot of iron, if you have a lot of free radicals, remember, iron is used to combat and oxidize, like literally oxidize pathogens. If you have a bunch of this stuff, then your body is going to try to minimize any source of ROSs, for example, type 2 diabetes. So out of those eight of 9 patients were resolved their insulin resistance completely just by removing a little bit of iron, decreasing the ROS load. Okay, the symptoms are going to be oxidative stress, joint pain, fatigue. It's just going to be this like really inflamed patient. Just remember, that bronzing of the skin, maybe cirrhosis of the liver. It is incredibly important to detect and address the early signs of iron overload. Research suggests that iron burden at levels within normal lab reference ranges increase your risk of cardiovascular disease 5-fold. Clinical trials using iron depletion showed a clear benefits in terms of improving measures, decreasing the blood pressure, reducing elevations in lipids. So basically, if you have too much iron, your chances of dying of a heart attack increase. And this is just from excess inflammation. What are causes of iron overload? So this is story time again. Women suffer from iron deficiency anemia way more often than guys because of their cycle. Okay, now imagine our ancestors, were not in front of a computer on a Monday night listening to someone drone about iron. They were out there hunting and gathering, and scrapes and injuries happen a whole bunch. So our body has developed all this evolutionary mechanisms to kind of hoard iron. But now with our very cushy and luxurious lives, sitting in front of computers, and at an office building, we don't have this bloodletting where we accumulate iron for many years, unlike our women, where they are having a little bit of blood loss every month. Okay, so I don't think that hemochromatosis, I guess, it could be hereditary, but if we are doing, a little bit of blood donation here and there, if and depending on your ancestry, you're going to be more prone to the accumulation of this red blood, of this iron. Over supplementation, taking just too much iron, and then bad HRT protocols. You've heard the horror stories about just doing super physiological doses of testosterone and then having to have your patients, as part of your HRT protocol, having to do blood donations or therapeutic phlebotomy. But thankfully, fixing hemochromatosis is very easy. Therapeutic phlebotomy, to your local blood center, and then having, being able to give back to the community in the form of having a little bit of blood donation. We need to make sure that it is reasonable, that that our patients comply. I think that's one of the things that my patients have the lowest level of compliance with therapeutic phlebotomy. But as a guy, I'm hard-headed, and I don't usually follow my own advice. So I can imagine that if you come to the office and then someone tells you, oh yeah, now you have to go to another place and wait a couple of hours, or and having to do this blood donation, I can see how that can that can be lost in the mix. So have a lot of patients that have joint pain or have a clear picture that maybe they have a little bit too much iron, and I go, come on, dude, you just got to do it. And they finally do it, and it's almost almost like with giving an iron infusion. My patient, I remember clearly, a patient said it while receiving an iron infusion. She felt like someone put a blanket, like a warm blanket over her, and she started feeling more energy, and she started feeling warm, and that was the mitochondria coming back in line. And I've had a patient of mine that had this joint pain, and he told me that as they were drawing the blood, that pain went from like a 10 or a 9 to a 3. And that right there fixed my compliance issues with him, because he received such good benefits from blood donation or therapeutic phlebotomy. Just make sure you guys have a good referral network. I know here in Arizona, we have forms at the office where you can fill them out, and you can tell them to how much to draw and what your hematocrit levels should be before you draw again, because we need to constantly monitor for anemia, and just making sure that we have a natural diet, that is the most nutritious, with all of those things that I mentioned, that we should be able to prevent that anemia. So don't over phlebotomize your patients. Well, and that was a whole lot of material. That was a whole lot of information. I'm gonna bring the camera back, and do you guys have any questions?
Wonderful. Thank you so much for that presentation. Yes, people can feel free to type questions, or if you would rather, you can raise your hand on that GoToWebinar control panel, and I can funnel those. But it looks like we have one here. How do you know if someone is deficient in phosphochlorine?
Phosphatidylserine?
It's choline. Sorry.
Yeah, phosphatidylcholine,
Yeah.
phosphatidylserine. That's a really cool one, because I usually, I don't test for that. That's one where I would just supplement it. You don't have to test everything and have like an answer for where you don't have to be you don't have to test all of those things. That phosphatidylcholine, that's one that if I have someone that I'm giving them the B12 and I've given the folate, and I haven't seen any results with that MCV going down, I go, you know what? Next step is going to be adding some phosphatidylcholine, and pretty inexpensive, and really, really helpful with anemia. So that's not one that I test. That's one that if I know that they have a solid diet first, that they're eating, their leafy greens, and they're eating good quality protein, and things are still not, jiving, that's when I go, okay, next step. So this is how we'll do it. I have an MCV that is trending to the high. So then what I would do is I would start with a B12 folate combination, or B12 injection, or lozenges, however I think, but most of the time it's going to be a combination of B12 and folate. If that doesn't fix that marker, then my next step would be to add phosphatidylcholine. And then if that doesn't fix it, and especially if they're doing like shakes, like a protein shake in the morning, then I add the creatine. Creatine, very inexpensive. I think it's like $14 for a kilo of creatine. Just make sure the label says Crea Pure. Crea Pure is it's better absorbed, and it's going to help with the formation of those so just think about it. You are diverting your resources, and it's going to help you satisfy needs that are upstream by giving the patient creatine, by giving the patient choline. Every single cell needs that phospholipid bilayer. So pretty common. So if you give an extra, like a little bit of extra choline, then it's going to be, you're going to be able to satisfy that. So no, I don't test. I just give them some phosphatidylcholine.
Great. And then a follow-up question to that. And since we're in the Q&A section, I think it's okay to say brand names of things. Obviously, we need to keep things, clean for the presentation. But the follow-up to that was, what's your favorite choline supplement?
Oh man. So I go back and forth. I don't have a favorite. Thorn, has a good product. I've experimented using Cerephos, which that's phosphatidylserine, but that phosphatidyltail tail can be used too. I'm still not sure if it's helping or not, but as you guys know, Cerephos is good to lower cortisol levels at night. So if you have someone that is kind of like a little bit nervous at night, can't go to sleep, you want to give them something that is going to tackle two things. Cerephos is a brand that comes to mind, but no specific brand. Same with the creatine. As long as it says Crea Pure, you're good to go. Same with the iron. Again, guys, if anyone has an iron brand that you guys enjoy and like, and you have seen, please let me know, because I've tried all of so many different brands, and they are good to maintain levels, but I'm not seeing very good results in increasing levels of iron.
Okay, great. Let's see. Okay. So this is a specific case question. It says, I have a 5-year-old with high eosinophils but low lymphocytes. Any ideas besides environmental allergies? Because all that came back was negative. Next, looking into parasites by a GI stool test.
Exactly. That's exactly, um, that's a difficult one, without having all the case study and everything. But been having, I bet everyone has seen it, especially here in Arizona. We usually have 2 growth seasons, and we've been very fortunate to have an extended spring and an early fall. So all those white blood cells are going to be elevated. So yes, parasites, make sure, look into those infections. And then secondly, doing some, if you can, did you do environmental allergies? And if you did, only 2 things came back positive. Doing, here in the Southwest, we can do an environmental panel that is specific for the Southwest that tests things that could be very problematic here, specifically to the Southwest. I'm not sure where you're located, but different regions have different panels. And so testing for that could be very, very important. And then using something like Seroslit or sublingual desensitization therapy to kind of retrain the immune system into not overreacting to this allergens. So that would be my first couple of steps. I've had a couple of patients with that same presentation that their thyroid was not just cooperating with me. Like those levels were all over the place. The TSH was not, I was not able to control it. And I gave them a little bit of Montelukast, a leukotriene inhibitor, to kind of like modulate that allergic presentation. And lo and behold, had a patient that had chronic urticaria related to her thyroid. So when her TSH levels went really high, bam, she would just break out in hives, and her asthma symptoms kind of were correlating to that urticaria. So I was like, well, let's go standard of care, try to see, what's going to be the different ways of modifying that immune response. Tried the leukotriene inhibitor, montelukast 5 milligrams daily, and she didn't need to use her inhaler anymore. She was working out in the mornings, and completely, to my surprise, her thyroid was finally able to be stable. So then I had, and a couple of months after that, I had a different patient with sort of like the same presentation, very allergic presentation, using her inhaler every day, and her thyroid was, all over the place. Did a little bit of montelukast, and again, bam, perfect. So I'm trying to dig into the literature. I'm trying to see if I'm missing a pathway, but I've been very fortunate with those two patients. So I wonder if by modifying and helping that allergic response, and we have all the different ways that we can do it. Nettles, we can do products like DHIST, without having to jump into the pharmaceutical. But I imagine that if for your endo patients, if we can control that, a lot of things fall into place.
Wonderful. Let's see. All right, that got answered. Wonderful. Let me just check and see if anybody's hand is up. All righty. Well, I'm not seeing any other questions pop up here, so feel free to type them as I'm making this last closing statement thing, and you can squeeze it in there. But if anybody does have any questions, or if you're listening to the recorded version of this on the EndoANP website and you want to follow up with the presenter, don't hesitate to shoot an email to endoanp@gmail.com, and I can forward that on to Dr. Ruiz and start a communication there. Or even better, I encourage everybody to engage on our fairly new EndoANP members Facebook wall. This is a great place to continue conversations and brainstorm, and we're really trying to make that a really awesome, valuable member benefit. But as you can imagine, it's only as good as how people interact with it. So that's just a little plug to utilize that benefit there. And yeah, Dr. Ruiz, any closing statements from you?
Yeah, just I'm gonna send you that PDF, and so we can share it with everyone. And again, you guys can give it away to your patients. You can you give it a read. I have the lab values included in there, so I hope it's useful.
Fantastic. All right. Well, thank you, Dr. Ruiz, so much for tonight's presentation. Thank you all who attended live, and to those of you who are listening to the recorded version. And hopefully you guys have all marked your calendars for our next webinar, which is about a month from today. It is, of course, now I'm opening my calendar right now. It is Monday, December 16th, and we are joined by Dr. Carrie Jones to discuss, I'm just trying to pull up I want to give her official title of her presentation and not botch it, but of course it's not pulling up right this moment. So join us. We have an awesome one. I will send you guys the email, which you should have got along with this one, but make sure you're registered for that. And everybody have a wonderful week. And for those US people, happy Thanksgiving next weekend. And for you Canadians, happy week in November. Good night, everybody.
Thank you. Good night.